Sir, enhanced recovery after surgery for primary hip arthroplasty, sir.
Okay. Primary hip arthroplasty. Not
Hip arthroplasty, yes, sir.
it's no primary or secondary.
Okay, sir.
Okay.
Eras pointed by Henrik Kellett in 1990 as an effort to improve recovery after colorectal surgery. He hypothesized that surgical stress, metabolic dearrangements, endocrine dearrangements, prolonged immobilization, which contributes to organ dysfunction like pain, nausea, vomiting, ileus, fatigability, cognitive disturbance. Hence, recovery is facilitated by a multimodal approach directed towards global modulation of surgical stress response. This can lead to superior recovery, decreased morbidity and mortality, decrease hospital length of stay, and cost savings. An ERAS team should comprise expertise from surgery, anesthesia, nursing, physical therapy, and nutrition. And the multimodal and multidisciplinary protocol for ERAS is preoperative education, preoperative nutrition, liberal fasting, optimization and reduction of comorbidities and to correct anemia, active pre-warming, preemptive oral analgesia. Intraoperatively, regional anesthesia is preferred over general anesthesia. A goal is to maintain normothermia and normovolemia. We should use short-acting sedative hypnotic agents, blood conservation strategies, and antibiotic prophylaxis. Post-operatively, multimodal opioid sparing analgesia like lumbar epidural, NSAIDs, acetaminophen, post-op nausea vomiting prophylaxis, early mobilization, and early oral intake. This pre-operative education most benefit the patients with depression and anxiety. It shows a significant reduction in the pre-operative anxiety. Pre-operative fasting guidelines now permit intake of clear fluids until 2 hours before induction of anesthesia and 6 hours fast for solid foods. It also upheld in obese, morbidly obese, and uncomplicated diabetes patients. It also recommends that patients consume up to 300 ml of clear carbohydrate-rich drink 2 to 3 hours before surgery, so that the patient should be in a metabolically fit state and the patient undergoes less post-op nitrogen and protein loss and they can maintain more lean muscle mass. Standardized anesthesia protocol, where the higher incidence of post-op complications under general anesthesia than neuroaxial or regional anesthesia, like pulmonary compromise, pulmonary embolus, need for transfusion, renal injury, infection, length of stay, and 30-day mortality are significantly lower after neuroaxial anesthesia. Comparing TIVA versus spinal anesthesia, there is a reduction in the length of stay, lesser nausea, but the patient might have dizziness and orthostatic instability in TIVA. Preventing and treating post-op nausea vomiting. Patients who are at moderate risk of post-op nausea vomiting, that is patient with 2 risk factor, they should receive prophylaxis with dexamethasone at induction or a serotonin receptor antagonist like ondansetron at the end of surgery. Patients who are at high risk, who have 3 or more risk factor, they should receive both dexamethasone at the beginning of surgery and the serotonin receptor antagonist at the end of the surgery. And dexamethasone, which increases blood glucose level in both diabetic and non-diabetic patients in a dose-dependent fashion. In a diabetic patient, it should be decided on an individual basis and it can be managed effectively with perioperative insulin infusion. Post-operative analgesia, it should be multimodal opioid sparing techniques like peripheral nerve block, use of acetaminophen and NSAIDs. Other choices like patient control epidural analgesia, peripheral nerve block, which could be single injection or continuous, periarticular injection, local infiltration analgesia. Excellent analgesia can be achieved by continuous epidural local anesthetic with or without opioids. And some study says gabapentinoids like pregabalin, which can be used to reduce the opioid consumption and prevents chronic neuropathic pain and also decrease the incident of pruritus and nausea associated with opioids. Early mobilization, it is the key component of ERAS program. It can prevent adverse physiological effects of prolonged bed rest, like increased insulin resistance, myopathy, uh, reduced pulmonary function, impaired tissue oxygenation, and there is increased risk of thromboembolism with bed rest. Safe and effective analgesia is a prerequisite to encourage post-op mobilization. This early mobilization will decrease the length of stay when patient ambulate within 24 hours of surgery. It will increase the functional recovery and decrease the incidence of DVT. Maintaining normothermia. Maintaining peri-op normothermia with forced air warmer to reduce post-op infection, cardiac complication, coagulopathy, and transfusion requirements. Aggressive warming results in reduced intra-op blood loss and reduced opioid need and greater satisfaction. But maintaining normothermia is against the neuroprotective effect of mild hypothermia. Short-term post-op cognitive impairment has been associated with warmer temperature in elderly patients. Antimicrobial prophylaxis. The Agency for Healthcare Research and Quality recommended cefazolin for primary hip and knee arthroplasty. Clindamycin and vancomycin should be reserved with the patients having cephalosporin allergy. Intranasal mupirocin is recommended for all patients with documented Staph aureus colonization. Antibiotic loaded bone cement might reduce the infection rate after joint arthroplasty, but the antibiotic loaded bone cement should also address concerns about patient's safety, risk of antibiotic resistant microorganism, and increase the cost. Intravenous fluid therapy. Goal-directed fluid therapy is a prominent component of ERAS protocol due to limited intraoperative blood and fluid loss and the early intake of post-op oral fluids. IV fluids should be judiciously used with the aim of providing routine maintenance fluid to meet insensible losses, to maintain normal status of body fluid compartments, and enable renal excretion of waste products. This can reduce post-op infection, post-op organ complication, and risk of blood transfusions. Blood conservation strategy. Anemia and allogenic blood transfusion is associated with immunomodulation, volume overload, increased incidence of infection, increased length of stay, and higher mortality. So options to increase pre-op hemoglobin without transfusion includes iron supplements and erythropoietin injections, which are associated with lower requirement for transfusion. Other strategies like hypotensive epidural anesthesia, blood salvage techniques, and pharmacological interventions like use of tranexamic acid, which is an antifibrinolytic, and it can be administered intravenously and also used as a topical. And there is no significant increase in side effect like DVT, pulmonary embolism with the use of tranexamic acid. Venous thromboembolism prophylaxis. American College of Chest Physicians recommend routine use of anticoagulants to prevent clinical and radiographic DVT and pulmonary embolism after joint arthroplasty. Choices are low molecular weight heparin, direct oral anticoagulants like direct thrombin inhibitor and factor 10A inhibitor, low dose unfractioned heparin, vitamin K antagonists like warfarin, and antiplatelets like aspirin, and also intermittent pneumatic compression devices. Minimal recommended duration is 10 to 14 days of thromboprophylaxis, and now suggest this could be extended up to 35 days. The safety of initiating venous thromboembolism prophylaxis with concurrent epidural analgesia must be considered. According to American Society of Regional Anesthesia and Pain, prophylactic low molecular weight heparin should be withheld at least 12 hours before insertion or removal of an epidural catheter. It recommends against the prophylactic use of low molecular weight heparin twice daily dosing in the presence of an epidural catheter. To withhold direct oral anticoagulants 3 to 5 days before performing a neuroaxial blockade, and waiting 6 hours after oral intake for removal or a manipulation of an epidural catheter. Urinary catheterization. It should be avoid routine usage of urinary catheterization, and if catheterized, it should be removed as soon as possible, ideally within 24 hours after surgery. Post-operative nutritional care, an early return to a normal diet should be promoted. Continuous improvement and audit. Routine internal and external audit of process measures, clinical outcomes, cost effectiveness, patient satisfaction and experience changes to the pathway, and it is recommended.
Finished?
Over, sir.
Okay.
Yes, sir.
Right. My first question to you is, who requires a hip arthroplasty? Who are the patients who need a hip arthroplasty? In your experience so far in this 1.5 to 2 years, you are working in a
Yes.
center with 9 ortho workload. So,
Yes, sir.
for which patient you do either a total hip replacement or a partial hip replacement?
AVN trauma.
avascular
Fracture.
necrosis.
Majority are fracture cases, isn't it? Elderly people with a fracture. Very rarely you may do it for rheumatoid arthritis, crippling. Okay. So,
Yes, sir.
is it possible to practice this ERAS in a patient with an acute fracture pain? Anybody can answer.
So,
Anybody who knows the answer, Ammu,
so we can wait for 48 hours till the inflammation subsides and we can mobilize the patient.
Okay, so the first answer for this question should be, you must be very careful in selection of your patient. Not all hip arthroplasty patients are fit for ERAS protocol. Like because ERAS protocol was, as she described, like Ella, he introduced it in patients who are going to undergo colectomy for colon cancer. Okay, so there it is a planned program. You evaluate the patient, you surgically you counsel the patient, educate them, you ask them to be seen by all the specialists as a OP, and then admit the patient just the day of surgery or on the previous night, do the surgery, and within 48 hours you discharge and send the patient home. That was the idea, to minimize the number of hospitalization days to minimum where possible, to prevent cross infection, to prevent excessive financial burden for the patient. Okay, so that was the idea with which ERAS was started. But the same protocol cannot be applied to all the patients coming for hip arthroplasty, because the two reasons. One, majority of them come with an acute condition of pain with a fracture. Second thing is, majority of them are geriatric patients, more than 65, 70 years old, isn't it? So these two things make ERAS protocol a little more difficult compared to how Keller introduced it for his particular purpose of colonic surgery. This is a very important point that you should keep in mind. So the selection of the patient and exclusion of the patients who are not fit for protocol. For example, a patient who had a MI after admission with the pain, can you do ERAS protocol and do the surgery and send him home after 24 or 48 hours? It's not possible.
No.
So the selection is very important. And once you plan this, you must give a extensive pre-op preparation. You must tell the patient, tell the attenders what you are planning to do, how they have to react. You have to discuss so many things with the patient, how you are to think. And the most important thing before you plan ERAS for a hip arthroplasty is to relieve the pain, acute pain of a fracture if the patient is admitted with a fractured neck of femur. So you must give pain relief. However much you give oral tablets or intravenous painkillers, nothing will work like a good nerve block or a fascia iliaca compartment block, which will give 100% and complete pain relief to the patient if done properly. Okay. So the first and foremost thing that you have to mention is pain control for ERAS program. If you plan ERAS for a patient with waiting for hip arthroplasty, is to control the pain. And majority of the institutions which follow ERAS protocol for hip arthroplasty start the pain relief at the emergency department itself. As soon as the patient is arriving in the emergency ED department, and once the surgeon sees the X-ray and says, yeah, this patient requires a hip arthroplasty, a total hip or a partial hip replacement, the next moment the patient is given a on block which will relieve the pain of the patient and make them more comfortable for shifting, taking X-ray, or CT scan, whatever you want, you can do that without pain for the patient. And this block is called, what is the special name given to this block that you give when the patient arrives into the ED or ER room?
On arrival block.
On arrival block. This is called on arrival block. Okay, this has become the in thing for the RAS protocol. That is the first point that you have to mention. Okay, and then you counsel the patient. So you can divide the RAS protocol into pre-op selection of patient, pre-op preparation and optimization, intra-op management, and post-op care. This is the 4 subheadings under which you should write this answer in your theory paper. Okay. So based on
Yes,
that, without wasting much time, I will show you a presentation